Hello, my name is Sarah Johnson. I'm an OB-GYN at La Clínica de la Raza, which is a community health center and FQHC in Oakland and the East Bay in the San Francisco Bay Area. And I wanted to create this training about ACE screening in reproductive health because I think we have an amazing opportunity in reproductive health to really take advantage of the current groundswell of interest and enthusiasm about responding to trauma for our patients, because we have so many touch points across the lifespan and we see multiple generations and see healthy patients early in their life course. So I'm excited to be part of a community of reproductive health providers figuring out what trauma-informed care can look like and how the current interest in ACE screening might come into play. I'm going to go ahead and share my screen, and I'm grateful to have you join this training. The title of my talk is ACE Screening and Trauma-Informed Care, a Resilience-Oriented Approach for Reproductive Health. As I mentioned, I'm from La Clínica de la Raza, and I also benefited from collaboration with Elizabeth Morrison Consulting and Selena Gupte, and from the ACEs Aware initiative from their support. The mission of the ACEs Aware initiative is to change and save lives by helping providers understand the importance of screening for adverse childhood experiences and training providers to respond with trauma-informed care to mitigate the health impacts of toxic stress. And you can get certified to screen for ACEs and bill for it if you are an eligible clinician by going to the acesaware.org website. There's a free training available called Becoming ACEs Aware in California. This training is kind of an adjunct to that. This training is the first in a seminar series convened in our East Bay area this past fall that used the foundation provided here with key concepts in ACE screening and trauma-informed care as a jumping off point to explore with experts from our area different dimensions of trauma-informed care in reproductive health. We examined the impact of structural racism from the perspective of patients in the East Bay seeking reproductive health care. We had a trauma-informed yoga instructor talk about how mindful movement and the embodied stress response relate to trauma-informed care. We had a psychologist from the UCSF Child Trauma Research Program talk about relationships and their role in healing intergenerational trauma. We talked about trauma-informed nourishment. We talked about restorative sleep and supporting exercise for women's health. And recordings of these seminars, which were really amazing, will be available on my website, traumainformedobgyn.com, starting early next year, early in 2022. I'm excited for people to be able to see these. They were a treat. The learning objective for this talk is to describe fundamental concepts for engaging with patients on resilience and addressing ACEs, trauma, and toxic stress in women's health using trauma-informed approaches. We'll talk about trauma and resilience. We'll talk about adverse childhood experiences, get into some details about adverse childhood experiences, trauma-informed care as a response, including ACE screening, bringing in empathic communication and self and collective care and putting it together at the end with a case. And I want to just acknowledge that we're at different points in our learning with this information and that there are probably different ways to engage with this material. In medicine, we tend to have a habitual way of engaging with information in our medical culture that's really problem-focused. And I am excited to see if we can balance this analytical bent with curiosity and also with noticing our own selves and our embodied reactions to the material as a foundational skill in providing trauma-informed care. So if this information is new to you, notice what comes up for you. Where might you be curious to learn more? If it's not new, think about how it's presented. If you were explaining this to patients or stakeholders, what might you use? What might you say differently? There are other emails or other information on the fundamentals available at the ACEs Aware website as well. So with that in mind, let's just take a few seconds to do a brief grounding activity with the idea that we'll connect to ourselves and our surroundings so that we can better connect to the material. This is something, a skill that many of us have that we can use in day-to-day care to be able to better respond to our patients where they are. So just take a few moments. I'll lead with what I often do. Arrive in the space where you are right now. You might look around the room, notice different objects. We can turn our head over our right shoulder and left shoulder. I've heard scanning the room activates the vagus nerve, helps us calm. And if you can, just let the different objects fade into one sort of visual scape. You can do what serves you, either let your gaze soften or close your eyes for a few moments. And just allow yourself to take a couple deep breaths. Thank you. I want to start by just acknowledging that this moment that we are all in is not the wrong moment to be considering trauma and its effects. We have been through and are still going through a pandemic that continues in its surges to challenge us, that has no cure, no clear endpoint. During this time, we've been through an extremely divisive moment in our nation's history with the elections and controversies following that. We are coming off a year where we took care of our families and kids at home. Here in California, we've faced environmental threats, drought, fires. We continue to confront the racism that is such a scourge on our society and continues to demand more and more of our attention as it deserves. This is a moment where we all actually can relate on some level to individual, collective trauma. And it's also worth noting that in moments where we can connect to trauma, sometimes it's more available to us to connect to things we're grateful for. The healthcare system was able to dramatically turn on a dime to launch telehealth. The way that our colleagues and our family members and community members have risen to the occasion to take care of people in the face of this exhaustion, the way that people have mobilized politically or for causes that are important, the way that each of us has shown up in this pandemic is worthy of a lot of gratitude and can give us access to that in ways that sometimes we have less access to. So what is trauma? I'm going to start with this definition, which comes from the Substance Abuse and Mental Health Administration, called SAMHSA. I'll read it because it's so important. Individual trauma results from an event, series of events, or set of circumstances experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. And this definition of trauma, there are many, but this one I find to be especially important. It helps us understand the complex nature of trauma. It highlights that it's not just an event, but the experience of an event and the effects that constitute trauma. It also points out the holistic nature of trauma. It's not just mental effects. Trauma affects people's mental, physical, social, emotional, and spiritual well-being. And we really need to embrace this holistic concept when we're helping people in their response to trauma. Humiliation, guilt, shame, betrayal, silencing often shape the experience and the effects of the event, which highlights how the community context and the historical context are very important elements too of how people experience trauma. Trauma can impact our relationships with ourselves or others. It can cause us to overgeneralize danger or threat in situations that might not otherwise seem threatening. Here's some examples of trauma, thinking through this framing of events, experiences, and effects. There are many examples, and COVID actually provides a look at some of the layers of trauma. Individual trauma has occurred for many people during COVID, people experiencing illness, often in isolation, family members who grieve without community support. Beyond just the effects on individuals, we can really see right now how trauma can affect whole communities. It can affect the collective. There's something about us all experiencing grief or loss as a group and society. We all had to shelter in place. We all saw the results of the collective increased fear and divisiveness and othering. The healthcare professions have experienced a collective trauma in our efforts to respond to COVID-19. And we can also think about trauma as historical, originating in the past and continuing to reverberate through structures and group and individual experiences. And that, of course, shows up in COVID as well. For example, in more severe cases of in more severe disease, worsen economic burdens on communities that our health centers serve. Finally, we can notice that the same event might cause trauma to one person and not to another. For example, experiences that we have providing healthcare. Of course, trauma is not the only possible result of experiences and events, and we have to look at resilience too. This definition of resilience is the one adopted by ACEs Aware. It says resilience is the ability to withstand or recover from stressors and results from a combination of intrinsic factors and extrinsic factors, like a safe, stable, and nurturing relationships with family members and others, as well as predisposing biological susceptibility. And of note, with scientific advances in the understanding of the impact of stress on neuroendocrine, immune, genetic, regulatory health, we're going to have to advance our understanding as resilience, as having neuroendocrine, immune, genetic, regulatory dimensions. So we're really expanding our definition, and different people might hold different definitions of resilience. I've noticed that in talking to reproductive health professionals about this. Some people in our field, I've noticed anecdotally, have a sense of resilience, and this might be part of the culture of our field, I think, of resilience, meaning that you have to be okay no matter what. And that's different from thinking of resilience as resulting from things like nurturing relationships and family members, or of biological susceptibility. So there's a lot of discussion about what resilience is. Some people might find it burdensome if they think it means you have to be okay no matter what, or exhausting or inappropriate if you're thinking resilience means it doesn't matter what structures dole out to you. You're so great, you can take any hit, and that's not fair. It can be exhausting. But there's all these different dimensions, wanting to balance the idea of individual resilience with the responsibility to fix the broken structures, and wanting to fully capture the resilience of different communities, thinking about behavioral, biological dimensions. Our human brains have a negativity bias, and our medical training focuses on pathology. So it can be easy for us to mistakenly equate trauma with pathology. And that's why I really love this first quote from Rachel Yehuda, who's an important trauma researcher. Because if we really stand back and understand the nature of trauma and resilience, we can see an incredible tapestry of adaptation and growth. Trauma and resilience both demonstrate human abilities to respond and adapt to our environments. We need to remember and pass on to our patients that over the course of a lifetime, there will always be opportunities to heal. As Dr. Yehuda says, it matters that we continue to have a conversation about resilience, because the meta message is that the experience of trauma does not only yield pathology. For this reason, I've tried to make it a habit to always think about resilience. I don't always use that word with patients, but think about this human capacity to adapt and respond every time I think about trauma. The second quote is something that stuck with me from an op-ed in the New York Times I read a few years ago. The author is reflecting on a study she's heard about in mice, prompting reflection about the intergenerational transmission of trauma. She says, in a study they did with mice, researchers concluded what we already knew, that trauma lives in our blood. Every time I tell myself that I'm worthless, how do I know if it's me thinking it or it, my broken cells? So this reference to her broken cells seems to fit with a message of trauma that doesn't include resilience or possibilities for healing and growth. And we can see how this kind of perception could be unhelpful, but it might be someone's reaction to what they hear in the media or what they learn about stress and trauma and how they affect us. So this I hold as a reminder of how important our conversations are with our patients, sharing that we know that broken cells can be healed and repaired. This is so important. And I want us to keep this in mind as we learn about the science of toxic stress and how to communicate with our patients in ways that support resilience. How are we going to bring the following material into our care of our patients in a way that offers a resilience-oriented message? Okay. So having framed trauma and resilience, we'll turn our attention to a hot topic in medicine at large, adverse childhood experiences. And I want to lend a little bit of a reproductive health lens to this information so that we can together imagine how we can bring it in and seize the opportunity that of this moment where everyone's thinking about ACEs to advance trauma-informed care in our field. So I'm sure many of you are familiar, but the term adverse childhood experiences comes from the landmark 1998 study conducted among more than 17,000 adult patients by the Center for Disease Control and Prevention and Kaiser. Two obesity clinic doctors noticed many of their patients had early traumas, and they wanted to look at the association between these experiences and health outcomes. The term ACEs specifically refers to the 10 categories of adversities pictured here in 3 domains experienced by the age of 18. That's what they evaluated in the study. So the categories include abuse, neglect, and household challenges. And the 10 specific instances are listed here. Now, these are obviously not the only types of adversity a person can experience. Other factors such as racial discrimination, separation from a parent or caregiver for reasons like deportation or migration, or even a medical trauma are also important adversities. In reproductive health, we certainly encounter adversities that occur in patients before they're 18 and after they're 18, or even trauma or adversity that occurs during people's experience of seeking reproductive health care or having children. So, when we're talking about ACEs, we're talking about these 10 specific categories because those were in the original ACE study. And this is important because we want to be clear about definitions and what's been studied and what claims can be made based on research. But we're also keeping in mind that we're encountering many adversities that aren't included in this group, especially in our field. Okay, so the important take home from the ACE study was that it showed a dose response relationship between adversity and health outcomes, but not only for conditions that were expected as results of adversity, like depression and suicide, but also with conditions like cardiovascular disease, diabetes, asthma, COPD, things that we think about as physical and not mental when we're using this mind-body duality. That's our habit. So newsflash, the mind and the body are connected. Maybe we should think hard about this and what it means for medicine. Importantly for us in reproductive health, many reproductive health conditions such as pregnancy loss, low birth weight, preterm birth, chronic pelvic pain, mental health conditions such as prenatal and postpartum depression, PTSD, and other postpartum psychiatric diagnoses have all been found to be associated with ACEs. So that same broad expanse of effects in mental and physical health conditions is seen in the dose response relationship between ACEs and conditions we see in reproductive health. So more about ACEs. ACEs are prevalent. Consider yourself and other people you work with, others around you. Over 60% of us have one ACE, and of those, 1 in 4 experienced 4 or more adverse childhood experiences. What about in medical providers and staff? What are you imagining? It turns out that in the research that's been done, the prevalence of ACEs was similar in medical students as in the general population. So we often think about conditions affecting patients and not us, but this is something that actually affects all of us. And that to me is an important reason that it needs to be taken into account in considering how we should adjust our care and systems, not just in a patient-facing way, but also in a provider and staff-facing frame. Very important to recognize that ACEs are not destiny. They are preventable and treatable, and they do not always result in toxic stress. And people who have experienced ACEs can thrive and live healthy, successful lives. Knowing that ACEs are among us as medical providers and staff, as we just mentioned, is a great window into this and into the complexity of trauma and resilience. We know that people need support. We can also see firsthand when we look at our colleagues how ACEs aren't destiny. People who have experienced ACEs have happy, successful, productive lives. We can take this even further to the concept of post-traumatic growth. I think for many people in healthcare, a history of ACEs or trauma has the potential to deepen the meaning of their work. In my case, part of the reason I'm drawn to trauma-informed care was growing up with a dad who's a child abuse researcher. And his motivation for being in that field came from his own adverse childhood experiences, growing up with a father who was an alcoholic. There was a lot that came with that for him, but one element was a deeper meaning and connection to the positive work he's done. So this is not to minimize trauma or say it has no negative effects, but just that it's always working with resilience in complex ways. And we're learning a lot more about the biological and social and behavioral dimensions of this intergenerational pattern, but that I think is especially interesting for us in reproductive health because we're really working across generations. So over the past 20 years or so, a robust body of science has emerged that shows how high doses of cumulative adversity experienced during critical and sensitive periods of early life development and without the buffering protections of safe, stable, and nurturing relationships and environments can lead to long-term disruptions of brain development, immune and hormonal systems, and genetic regulatory mechanisms. These changes together are termed the toxic stress response. So ACEs and other adversities like racism and family separation are risk factors for toxic stress. And in clinical practice, we then see downstream effects in multiple body systems listed here. So endocrine, metabolic, reproductive, neurological, psychiatric, behavioral. And the opportunity here is that we now understand the shared underlying physiology to these downstream effects. So a patient we see might have a behavioral health clinician addressing depression, a women's health provider addressing pelvic pain, a family medicine provider addressing diabetes, even be involved with issues with clinic management because of behavior. And it may all have the same underlying cause, which presents an opportunity to work together upstream of the pathological conditions. I also want to highlight the concept of epigenetics here. You can see it between the clinical implications as the mechanism for the toxic stress responses downstream effects. I'm sure many of you know epigenetics refers to changes in organisms that are caused by modification of gene expression rather than alteration of the genetic code itself. Epigenetics are like dimmer switches on our DNA. I've heard that analogy and I thought it was helpful. Deciding which elements of an organism get turned up or down. Fascinatingly, especially for a multi-generational practice like ours, the same neuroendocrine immune changes that occur in individuals can be passed across generations through effects on the DNA of sperm and eggs or through in utero exposure. So this is kind of a biological correlate of the historical trauma or of the intergenerational resilience we have been talking about. And it can be a mechanism of transfer of environmental influences across generations. This is kind of what the woman in the quote was talking about in the study of the rats and the shocks. So in terms of addressing this underlying common physiology, it's really important to note that toxic stress physiology is not inevitable and it doesn't have to be permanent. So these pillars of wellness, I like to think of them as pillars of wellness. ACEs Aware has termed them stress busters. So that's another term. These are some of the things that we know through good evidence can help buffer and support and shift toxic stress physiology. And we can keep these in mind when we're collaborating to address underlying physiology. We are not all trained in all of these elements, and that can be intimidating, but we can lean into our own self-care learning about this. We can rely on our broad team, our community more at large, and the curiosity that I alluded to at the beginning, to begin to bring these different elements into our care of patients. And that was actually the idea at the basis of the seminar series that follows this talk. How can we think about each of these elements of resilience capacity and bring them into healing trauma and preventing toxic stress and healing it as well? And again, the team is really important here. So at FQHCs, we have the CPSP program. Each health center has different resources, but this is really a way to think about other colleagues, about the ecosystem of care, about the environments we have, and bring those all into healing. So zooming out from people's bodies and the toxic stress response, we also want to put this into context and think about how toxic stress interacts with contextual and structural issues. The concept of social determinants of health helps us think about how equity and questions like why our patients at health centers are suffering so much from COVID, how those pieces all fit together. And to me, this is where you can really hear the different gears turning in driving sickness and inequity. So as we know, social determinants of health are conditions in the environment in which people live, work, learn, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So when social determinants of health conditions are inadequate, unmet social needs arise that for individuals may directly result in toxic stress. They also make ACEs more likely to occur, and they make ACEs more likely to result in toxic stress due to the lack of buffers. And on a structural level, we have systems of power and resource allocation in place that create unequal distributions of the social determinants of health among different communities, driving the equation of ACEs and toxic stress and contributing to health inequities and disparities we see in populations. So this is happening on individual and populations levels, and racism is operating here on these structural, interpersonal, and individual levels to work with social determinants of health and adverse childhood experiences and other adversities and drive the health inequities and health disparities we see. And we want to keep that context in mind because we're working with individuals and that may be our sphere of influence, but we also need to think about the bigger systems and what we need to do to change them. So what does this look like when we think about ACEs in a family-centered reproductive health clinic like ours? We can envision the effects of exposure to ACEs and toxic stress as a possible negative cycle, perpetuating trauma, adversity, and poor health that ripples through families across time, depicted here as a cycle to emphasize the life course and intergenerational elements. Intergenerational transmission of toxic stress happens when ACEs or other adversities alter parent biology or behavior in ways that affect the development and health of their children. So for a parent affected by ACEs, there can be preconception and in utero exposure to toxic stress physiology that has next generation neuroendocrine immune effects. Parents' early experiences can come up and interfere with offspring early life experiences like responsive caregiving, which ideally would be in place to create the physiologic foundation for resilience. And then effects of ACEs, such as ACE-associated health conditions like mental illness or drug use, then become ACEs experienced by the child, since having a parent with a mental illness, for example, is an adverse childhood experience. Ensuingly, the toxic stress response in a child's body can then perpetuate the same cycle when the child later becomes a parent. So that dismal pathology focused view is not the whole picture, right? When we look at what's actually possible in a body that's adapting to its environment across the life course, we can see many opportunities to shift and interrupt this cycle. We can use the stress busters at any of these points. And every time we interrupt this cycle, we're doing primary prevention for the next generation. We can all kind of imagine our role in interrupting the cycle as someone providing prenatal care, for example. Upon learning this, I've really leaned into trying to help prepare my patients while they're pregnant to offer responsive and nurturing care to their babies. Thinking of that as primary prevention for next generation toxic stress and as a way of interrupting intergenerational trauma. There's many, many touch points, and this is where we all need to collectively come together and figure out how we can do this in reproductive health. But to me, when you look at the mission of our health centers, at our mission as reproductive health providers, and all the touch points we have with patients across the life course, the resources that we have that can be deployed through this lens of preventing and healing toxic stress, it really seems like a no-brainer that this is something we should be engaging with at our health center and together as reproductive health professionals. So I think we're supposed to be doing this. I just want to do a bit of a deep dive into stress and the symphony of kind of mind-body interactions it represents, because I think untangling the concept of stress and toxic stress is really key to a resilience-oriented approach. We don't want to be sending the message because we understand the potential impacts of trauma. We don't want to be sending a message that all stress is bad, and we really need to understand how to think about that. So stress, just a little point on this, distinguishing toxic stress from other forms of stress. So stress in the definition adapted by ACEs Aware is a real or interpreted threat to the physiological or psychological integrity of an individual, which results in physiological and or behavioral responses. So in this diagram on the left under positive stress, you can see that in response to an example stressor like a big game or getting a vaccine, there's a positive stress response. This is a brief activation of a stress response with an elevated heart rate, blood pressure, and hormone levels, and the system is set up to return to baseline. So our systems have natural buffers against the toxicity of the stress response. In the middle box, which is labeled tolerable stress, a different stressor is associated with a time-limited activation of the stress response, resulting in short-term systemic changes, and there's still a return to baseline. In this context, maybe buffering of stress, for example, by a supportive relationship, can help the return to baseline, but there's still a return to baseline. And the third box, what's labeled toxic stress, for example, in response to severe, repeated, prolonged adversity without the buffering effects, for example, of a supportive adult, prolonged activation of the stress response in children disrupts brain architecture and increases the risk of health disorders. There's not a return to baseline. That's the key thing. A new baseline has been established, and this harkens to the pathophysiology of the ACE-associated health conditions we've been talking about. You can imagine how something like elevated glucose, which could be helpful in a big game if you need to run around, could be harmful if it becomes the new baseline. For example, elevated glucose as a baseline is diabetes. So this may be a good time to pause and just take a break, and we'll come back in a second and think about what to do about this information. Okay, so what are we going to do about the impact of adversity on health, in particular in reproductive health? We're going to talk a little bit about how to approach this issue in patient care and then get a chance to practice with a case. So trauma-informed care, also known as a trauma-informed approach, is the framework that has emerged to create systems and practices that are able to address trauma's impact. There's a really important, very readable, and very useful SAMHSA document from 2014 that's cited in the notes here and that you can find just by Googling. That's very useful and instructive on this topic. And here we have, the adaptation of that ACEs Aware developed, this trauma-informed care framework. So trauma-informed care recognizes and responds to the signs, symptoms, and risks of trauma to better support the health needs of patients who have experienced ACEs and toxic stress. And in the ACEs Aware formulation, it's a framework that involves understanding the prevalence of trauma and adversity and its effects on health and behavior, recognizing the effects, training leadership, providers, and staff on responding to patients with best practices, integrating knowledge about trauma and adversity, not just into direct patient care, but policies, procedures, and practices, and resisting re-traumatization by approaching patients who have experienced adversity with non-judgmental support. A tagline sometimes used to convey the frame shift of trauma-informed care is that instead of asking what's wrong with you, which is a pathology-focused question, we're asking what's happened to you, a question that carries the recognition that physiology and behaviors are the result of multiple inputs, including experiences, environment, and predisposing factors. When we open the space for the question of what happened to you and the space for the patient to share their story, we can open up to this trauma-informed approach. The principles of trauma-informed care are a guide of how to develop and implement trauma-informed environments, systems, policies, procedures, and to guide our interaction with and care of patients. And a lot of these principles are ones we would want to see in any relationship. Things like safety, trust, collaboration, and sensitivity to race, ethnicity, culture, and identity. In many ways, trauma-informed principles help guide us in relationship-based care. So the mission of ACEs Aware, as I mentioned, is to train providers to screen for adversity. And we can start to think about why this might be useful, a useful thing to do. Screening for ACEs and the risk of toxic stress and providing targeted evidence-based interventions for toxic stress, like the stress busters that we talked about, can improve the efficacy and efficiency of healthcare, better support individual and family health and well-being, potentially interrupt the intergenerational transmission of ACEs and toxic stress, and reduce long-term health costs. So the National Academy of Sciences, Engineering, and Medicine recommends adoption of screening for trauma and adversities early in life to increase the likelihood of early detection. We want to be able to screen and respond in the clinical encounter or with referrals to bring protective resources to bear when early life adversities are detected through coordination of cross-sector expertise. And for adults, we can improve the treatment of ACE-associated health conditions if we understand that ACEs may be a root cause, and offers the opportunity to prevent the vertical transmission of ACEs and toxic stress, because we are bringing this into the conversation with parents and have an opportunity to plan with them and collaborate with them on what kind of circumstances, environment they want to offer to their kids. In reproductive health, it's especially relevant. In addition to the value of screening for adults, there are several ways screening pregnant women and their partners can support their and their child's health. ACE screening can help identify the risks to reproductive health because of the ACE-associated conditions we talked about previously. ACE screening promotes a positive cycle of health by reducing intergenerational transmission of ACEs and toxic stress. And again, this would be through a response that collaborates with patients to shift the context that their children grow up in. ACE screening can support the provision of trauma-informed reproductive health services. Patients' experience may affect the healthcare that we are trying to provide and their experience of that. And if we ask them about their experiences, we can make plans for them to have a positive experience with reproductive healthcare. For adults 18 and older, the ACE questionnaire for adults was adopted by ACEs Aware from the Kaiser Permanente and CDC work, and you can get this online. And this is the one that we can use to bill. And essentially in a clinical response, so we're going to ask patients about ACEs. We're going to apply the principles of trauma-informed care, such as establishing trust, safety, and collaborative decision-making. And then we can supplement usual care by providing patient education about toxic stress and offering strategies to regulate the stress response, including these stress busters or pillars of wellness that we've mentioned. I think it's really interesting. Many of these are integrated in one way or another into our reproductive healthcare. And so adding a trauma-informed lens using skills we already have or can further develop to connect with patients, and connecting the dots with patients so that they can bring their own curiosity about these elements together with the health conditions they're experiencing, and create a context for more holistic care that really reflects the way trauma impacts us, is what we're doing with this clinical response here. So again, you can screen for ACEs and talk to people about risk of toxic stress. Then we want to validate existing strengths and protective factors. We can refer to, we can give references to educational materials or other professionals. And we also just want to follow up, revisit the conversation, and monitor ACE-associated health conditions as indicators of treatment changes. And this is something that's going to be evolving as we increase our understanding of the impacts of adversity, learn more about how adversities other than ACEs impact physiology, improve our screening tools, et cetera. But this basic ask about it, connect with the patient in a trauma-informed collaborative way, and respond with a holistic approach is, I think, an excellent framework. A little bit of attention to healing and relationships. Again, reviewing the ACEs aware workflow, we're going to screen, assess for signs of toxic stress, and respond by providing referrals and supporting engagement and evidence-based strategies. We're taking the trauma-informed care framework, which involves an understanding of trauma and adversity, and applying it to ACE screening. CalQuick is an organization that's, it was a collaboration with ACEs Aware that our clinic participated in the past year. I had the opportunity through the program to lead our team in a project implementing coordinated perinatal and pediatric ACE screening. And for me, CalQuick's focus on relationships helps put this inquiry and response into a relational context. It can be a little bit intimidating to us as medical clinicians to bring this trauma content into our space. So this relationship focus helps think about how to have a conversation and create a relationship with our patients that brings in the principles of trauma-informed care. Relationships, including those we have with patients, are a foundation for health and well-being. When we connect with patients in a safe and supportive way about challenges they've faced, we're bringing ourselves into the healing equation. Our safe relationship can be a foundation for healing and also can be a model for the patient in relationships going forward, other relationships that can support them. So taking an empathic interest in the patient's experience, what happened to you? In the context of ACE screening, we can ask supportively how ACEs impacted our patients' health. And we can connect with patients' strengths, resources, and supports, including our evidence-based strategies for mitigating toxic stress. And returning to those strategies with this relational perspective on our interactions with patients during ACEs screening, we can see that our own relationship with the patients as an example of a healthy relationship can be part of what helps heal and mitigate toxic stress for our patients. So with that potential power of relationships in mind, we wanted to focus a little bit on some basic skills for empathic communication. And many of these are things that we do instinctually or on purpose. But we'll take a moment here to further explore the how of relational healing. So these elements of empathic communication are evidence-based skills for how we can create this relationship in the context of a trauma-informed approach. And it's worth thinking before we tackle those skills of some examples of what we often do in communication with patients. Some of these are actually essential parts of our roles and training, and we can see how doing something like explaining or giving advice can be needed in conversations about ACEs. But based on our training and our roles, we might be inclined to jump right into these elements, like explaining our advice. However, if we bring awareness to our interactions with patients and have a desire to strengthen our connection and ensure trust and collaboration as that relational foundation, we may choose to intentionally include reflective statements conveying empathy to establish a trusting collaborative relationship as part of trauma-informed care. So the suggestion here is going to be to consider holding empathy through the techniques in the next slides, especially when people are sharing difficult stories or circumstances like trauma histories, before or in addition to the elements above that are more like explaining or advising. Okay, so the first technique is an empathic reflection. In an empathic reflection, we can reflect back to a patient what we hear and observe to show that we understand. We might use their words, reflect emotions we detect, and summarize what they're saying. So if this patient's saying, I'm just so overwhelmed, like I can't get a break these days, I'm so worried about my son, you might say, you're so overwhelmed. Sounds like you're really worried about your son. So again, using their words, reflecting emotions we detect, and summarizing what someone's saying. You don't have to do all three, but those are ways to go about it. An affirmation is when you notice and articulate someone's strengths. So often you could start with, I'm impressed with your, or I appreciate your. So here in response to the same sentence, a provider might say, I can hear how much you love your son and how much you want to help him. We often talk about a strengths-based approach, and an affirmation is an example of how we can bring this in. And then normalizing is letting someone know that what they're going through is not uncommon. So anyone would feel that way. So in the same, in response to the same statement, a provider might say, many people are feeling overwhelmed right now and worried about loved ones. All of these skills in empathic communication are just as useful and applicable in telehealth, and perhaps even more so in the context of distance. We can use these skills to let others know what we hear and understand, and that we care about their experiences. And that can be really important, especially in this COVID age where we're talking to patients remotely. One final point before we move into a case. As we're thinking about ourselves as part of the equation of a healing relationship, and as whole humans who bring our own experiences to the table here and need to be cared for, self-care and resiliency naturally come up. Just as we need to think about individuals and structures when it comes to patients, we were talking about individual relationships or individual resilience, but also structures that affect the context of trauma and resilience. We have to think about the same thing with self-care and resilience for providers and staff. So we're often thinking just about self-care, individuals within an ecosystem doing things to develop self-regulation skills, reflection, attunement, taking action for their own needs to be communicated and met and heard. And that is important, but we also want to think about the culture and organizational structures and practices and policies and relationships that shape the context and allow self-care to happen. So again, this individual systems interaction, and we're thinking about not only self-care, but also collective care. And it's really important for us to keep ourselves in mind and the structures in which we operate as we move towards trauma-informed healthcare and reproductive health. Okay, so let's think through a case. This is a 33-year-old G1P0 who presents for routine prenatal care. She has a history of depression and chronic back pain, both of which she thinks are poorly controlled. She recently stopped exercising for fear of hurting her pregnancy, and she expresses concerns including being isolated due to the pandemic. She does the ACE questionnaire and answers with a score of 2. And then she shares that she was adopted at the age of 2 from a household where her parents used drugs, where severe abuse and neglect occurred, but she's not sure of the details. So on examination, she has some flat affect, but otherwise her examination is normal and a live fetus is seen on ultrasound. So questions to consider, and you might want to pause and think through these, talk about them amongst yourselves if you're watching with more than one person. We can think about what's the ACE score versus what the patient discusses. Are there any ACE-associated health conditions present? What are some of the protective and risk factors? What's the risk for toxic stress? I'll let you pause and look through this if you want to think through it with yourself. And otherwise, I'll just talk about some of the things that came up in the discussions of the live groups where I presented this. But one thing that's interesting here is the patient gave an ACE score of 2, but then alluded to potentially more adversities than the screener picked up. And that is something that is just reveals potential limitations of the screener, so that we need to have our minds on a range of adversities besides what's detected, but the ACE screener can really be a jumping off point for discussing these things. Protective and risk factors. Protective factors, this patient has a lot of individual resilience factors going for her. She has seen a therapist, she likes exercise, she was adopted by adults that may have offered supportive and protective relationships. But she also has some ACE-associated health conditions, chronic pain and depression. So it's possible that there's toxic stress physiology at play. Offering a reflection, affirming strengths, or normalizing. So think about what those might be. Wow, it sounds like you've really done a lot to take care of yourself. And I know that those things will help you have a healthy pregnancy. That's really true, for example. How could you support her in mitigating the effects of toxic stress? Leaning into somebody's own curiosities and interests, things like exercise, for example, can be a great way. We don't want to slam our patients with a litany of more things they're supposed to do. That's not what the pillars of wellness or the stress busters are about. What about those things that were healthy for you before you were pregnant sounds useful now? Do you think it would be useful to engage in exercise? Certainly, as a reproductive health professional, we can help somebody feel comfortable doing that and do that safely. Collaborating with mental health professionals when possible during pregnancy is certainly a huge strength. And bringing in the other stress busters or pillars of wellness where patients are curious and where we have resources. So this next question has to do with our own self-care. Noticing your own body and mind experience as you imagine yourself in this situation. What's coming up for you? What would you do if a patient becomes stressed out by this questionnaire? How would you talk to them? So things that came up in groups that I've talked to and that I've used myself, one is, and I've talked to a lot of behavioral health professionals thinking through this as well. Certainly we know our own grounding and self-regulation is something that has a huge impact on an encounter like this. And it kind of goes against a lot of the pressures we're facing as clinicians, seeing people in quick visits with kind of just an overloaded feeling. So just doing something simple like a few deep breaths for grounding can help provide space and contain things. I think that's probably like step number 1 is grounding our own physical selves, supportive and reflective comments, knowing that you can talk to the patients more at a future visit, and having a list of referrals and resources available before you start talking to people about this, so that you don't feel like you are personally having to manage all of this. That said, I will say anecdotally in my experience screening pregnant patients for ACEs, this coming up in a safe place in a contained context is not something where I've seen most people feel like they need to disclose their entire story. And certainly you don't need to know the details of someone's trauma to help them heal from it or to support them. And it's the exception rather than the rule that patients, in my experience, have needed to take a lot of time talking about their trauma, or have had emotional reactions that I felt like as a non-behavioral health professional, I couldn't contain just with my own self-regulation and offering support. I've also found that the disclosures that occur in these contexts tend to be a foundation for a much stronger connection with that patient that feels a lot more fruitful over time. This last question also gets to our own self-care. So how would you manage your own stress response within the organization, what would help to support your well-being and your ability to take care of the patient. So this is getting to our own experiences coming up, and the kind of context that we're having those experiences in. You know, what kind of day are we having? What are our relationships like with our colleagues? What supports are available? And this is just to start to get us to think beyond just, it's not just my own individual resilience and that I have to meditate and I have to see a therapist. We really want to think about these relationships and interdependencies we have in our clinic. And if we're in a position to, about the policies and context that create that experience for clinicians, knowing that this is challenging, that we all come to this with our own personal lived experiences, that providing reproductive health care can itself be a traumatic experience, and that patients' experiences can be reminders of our own experiences. We're having a human experience too. So what can we do for ourselves, and what can we do collectively together as people in relationships with colleagues and as organizations? That's where we're wanting to think there. So in closing, we just want to summarize some of the elements we've discussed. Knowing for our patients, we can teach people about trauma, resilience, and ACEs and other risk factors for adversity to offer a path to better health and well-being. That's the point. Preventing and healing from trauma and toxic stress is possible throughout the life course. We really need to remember this resilience-oriented message, even if we don't use the word resilience, because without it, this pathology-focused lens is not going to be helpful for people. We can screen for and respond to ACEs, provide treatment for toxic stress, and follow the principles of trauma-informed care, and offer follow-up and connection to resources as just concrete clinical things that we can do now based on the science of adversity and toxic stress and resilience to improve patient care. And for ourselves, remembering, you know, we have all these technological, science-y clinical tools, but our relationships with patients and our own well-being are part of this healing equation, and we can reflect on and develop personal and structural supports for our well-being. So I just want to thank you for watching. As I mentioned, this talk is the jumping off point for the seminar series that we had this fall that will be available at the website listed here, traumainformedobgyn.com, in January of 2022. And I hope if you're interested, you'll check that out. I'm really interested in collaborating with people in the reproductive healthcare community to advance and create together trauma-informed care in reproductive health. So please feel free to reach out if interested. Thank you for watching.